Hi and welcome to PHYSIO-FACTS. This is Dr. Alphonse Savaraswamy. Today I am going to show a video on fracture in children. A fracture in children is different from fracture in an adult in anatomical aspects as well as the physiological aspects. Let us see one by one. A child have a growing skeleton and their bones are springy. They have loose periosteum. And based on the fracture site, the healing of fracture, and the remodeling processes, a child fracture is different from an adult bone fracture. Growing skeleton. A child bone grows both ends, or a short bone have one growing end. Cartilaginous growth plate, which is potentially a weak point. This leads to epiphyseal injuries, which may affect the growth of a limb. A springy bone. A child bone is a springy bone in the sense it will deform before it gets fractured. This leads to green stick fracture where one half of the bone or cortex broke, the other side of the cortex still have contact. Loose periosteum. Because of its loose periosteum, it is easily striping off, leading to considerable hematoma, which gets calcified and becomes a callus. So faster healing is possible in children fracture. Based on the site of fracture, children's fractures are very different from adult fracture. There are common sites of fracture in children. They are supracondylar fracture of humerus, fracture of lateral condyle of humerus, epiphyseal injuries, spiral fractures of tibial shaft. Fracture healing. Fracture heals quicker in a child, as we studied before, because of more hematoma formation because of the loose periosteum. Remodeling. Remodeling, again, it is very fast in child fracture based on age of the child, location of the fracture, and degree and angulation of fracture. Types of fracture in children. First, birth fractures. Three types of fractures may occur in a newborn. Fracture or epiphyseal separation, which happens during difficult delivery, frequently seen in humerus shaft fracture, less frequently shaft of femur and clavicle fractures. The next one is multiple fracture associated with congenital fragility, for example, osteogenesis imperfecta. The third one is pseudoarthrosis of tibia. An inherent indolence of fracture to unite. Indolence means poor healing process. Inherent poor healing process of fracture to unite. Second is epiphyseal injuries, mostly seen in growing skeleton, may result in irregular bone growth and shortening. This is classified by Salter and Harris. They classify 5 types of epiphyseal injuries. Type 1. Separation through the physis. You can see in the diagram, there is no exact fracture, but there is a separation of bone from the physis, that is growth plate. Potentially, the growth plate is not having severe injury there. Type 2. Fractured through portion of the physis that extends through the metaphysis. Here there is fracture in the metaphysis and some portion of the physis is injured here. The third one, fractured through the portion of the physis that extends through the epiphysis into the joint. So this is considerably more severe than the type 1 and 2. And fourth one is fracture across the metaphysis and physis and into the epiphysis. So it is more severe than the third one. And the last is the most severe case, crush injury to the physis. If you see here, the bones are not broken, but the growth plate, the physis, is completely crushed. So based on the involvement of the physis, it is categorized. The most severe is the one, the type 5, where the entire epiphysis is getting crushed. Let us see a small example of an X-ray, AP X-ray of the shoulder of a child and an adult. I am trying to show the epiphyseal end plate, growth plate, which is seen as a mark in the X-ray. That shows the ossification process is not yet completed in a child. For novice people, an inexperienced person like a student, second year or third year students, when they look at an X-ray, they should think about the age of the patient. If they are a child, these lines shows the growing plate which is not fused with the epiphysis. They should not mistake as fractures. If we see here X-ray of a shoulder, anterior posterior, here there is no such marking. Here it means ossification is done, there is no marking. But when you see X-ray in a child, you have to think about it and you should not mistake this as a fracture. Now, third point is shaft of long bone fracture. In terms of displacement, it is very less. In children, displacement is not much. Usually, green streak fracture is seen. In the sense, it won't break end to end, but there is some portion of a bone will be in contact. If you see here in this X-ray, this side of a cortex is broken, but this side is still having contact. Again here, that gives a bend appearance without a complete displacement. So, end-to-end alignment is not mandatory, or malunion gets corrected with growth. That is the advantage of soft healing in a child fracture. Pathological fracture, which is very rare in a child, but there are possibilities. It may be because of fracture through the infected bones, fracture through cysts as in tumors, fractures associated with osteogenesis imperfecta. So far we were reading about the types of fracture. Let us come to the diagnosis. Usually diagnosis is missed in a child because the history is concealed. It is like a secret. People were not able to understand what has happened to the child because the child cannot communicate appropriately, or absence of dramatic signs of fracture. There may not be much displacement or deformity because they will usually go for green stick fracture. Otherwise, parents may attempt to conceal the fact of injury. For example, battered baby syndrome. If they beat a child, if they have fracture, they usually try to conceal or protect the event why it happened. Irrespective of the history, possibility of an injury should always be considered whenever marked loss of function, pain and tenderness, and unwillingness to use a limb occurs in children. This is the key point to go for diagnosis. Treatment. Non-operative and operative treatment. In non-operative treatment, plaster immobilization, traction, sling, etc. as a conservative management. Usually, a fracture in children will heal faster. Operative treatments. Operative treatments are required in the following conditions: fracture neck of femur if it is displaced, fracture lateral condyle of humerus like type 4 epiphyseal injury, fracture of the shaft of femur in an adolescent. In avascular injuries, the fracture is also fixed internally. These are the examples of operative methods where is used in a fracture in children. Complications of fracture in children. They are very few. Non-union, again it is very rare. Growth disturbances in epiphyseal injuries, which is common. Brachial artery injury in supracondylar fracture of humerus, which is a common fracture in children. Myositis ossification around the elbow. Avascular necrosis of fracture of the neck of femur. Thank you for watching. If you like this video, please do subscribe my channel and share to your friends. Thank you.